morning. Our first speaker needs no introduction. He's going to bring in some physics into surgery. So, Michel, bonjour.
Thank you. Thank you very much. Thank you, Sanjay, for the invitation. Thank you, Jatan, also. And it's a pleasure to be here in London and to present to you on linear magnets in bariatric surgery. So these are my disclosure. I created a company 5 years ago called GT Metabolic, who makes linear magnets. And during the pandemic, wrote a book on magnets in surgery from Springer. Currently, we have 3 magnets that are approved in 12 countries already, and 2026 will be a record because of the number of countries where this is going to be available. This is 3, 4, and 5 centimeter magnets for small bowel anastomosis. Magnets, super magnets, are made of neodymium. In fact, they are made of alloy of iron, neodymium, and boron. And the source of rare earth is mainly from China, neodymium. Second producer is the United States, and third one is Myanmar. But between the first and second producer, there's a 6 times in order. And so it's very difficult to find neodymium. And there's a single mine in California in the United States that is responsible for the US production. And neodymium comes in this material, but to make it a supermagnet is very complicated. There's an intermediary process in which the powder has to be heated. It has to be put in molds. It has to be heated again. And after this process, it has to be magnetized. It's not a magnet, it's magnetized. And then you get a supermagnet. Now, this supermagnet is toxic for the body. So we have a temporary implant, and it has to be covered completely with titanium or some other covering that is sealing the neodymium completely. So this is the complexity of the production. Now, magnets are not the first time that we use magnets in surgery, and there are animal experiments and other applications that have been used for 40 years. The Russians have been really active in the end of the 70s and early 80s. And you can see the first clinical application of colorectal anastomosis in the Netherlands. This was obviously in open surgery. And Kotlovsky has written a good manuscript 2 years ago about the experience of the Russians, and mainly in pediatric surgery, where they did gastrointestinal and urinary applications at Filatov Children's Hospital in Moscow. And these are the pioneers, and after the fall of the USSR in 1989, all this application stopped. I think the funding and the source for this research just did not continue. Today we have several companies that are making magnets. This is the linear magnets from GT Metabolic, and this is the first prototype that it is completely covered with titanium. And you've got GI Windows, who makes octagonal magnets, and the circular magnets that are made from the company Magnemosis. Now, we are all taught that anastomosis must be done immediately, and most of the time we do that, but anastomosis can be done remotely or delayed. And that's the use of the linear magnets, because there is a slow progressive compression, and between the 2 magnets is tissue that die. That's not where the anastomosis is happening. The anastomosis is happening around the magnets at the junction of the necrosis. And because you're not opening bowel, in most of the cases, you don't have an immediate risk of bleeding or leaks. To deliver those magnets, you have to attach them to catheters in front of an endoscope. You have to have laparoscopic positioner device. So these are magnets on a stick for laparoscopic surfing of the magnet, and you have accessory instruments. There's a whole array of instruments that are being developed that are non-magnetic, because all our open instruments, all our laparoscopic instruments are mostly made of stainless steel, and our needles. And they stick to all these magnets, and they create, slowing us down during the surgery. The magnet, as I said, is in the center and is covered with titanium, and our second generation has an absorbable flange made of polyglycolic acid. So this is the same material as an absorbable suture, and the idea is where the healing process takes place, the anastomosis, is between those two flanges, and they will disappear or break down in 2 weeks, which we think is the best time for a stronger anastomosis. Not at 7 days, not at 10 days, but 14 to 21 days, where you have more collagen deposition and less risk of getting a leak. Because you have a single magnet, it will orient itself always in the perfect position. And as the tissue gets closer and closer, the force between the two magnets is stronger and stronger. And therefore, what's left in between, once the magnet passes, is some sort of exoskeleton membrane of all the cells present in the two layers. And if we want to make a larger anastomosis, we just have to increase the length of the linear magnets. And linear magnets is like an endo-GIA, as opposed to a circular magnet who's more like an EEA. So we know that we can make circular anastomosis with an endo-GIA anywhere in the GI tract. So for example, in order to make an 80 millimeter equivalent circular anastomosis, it would require such a large circle, and that circle would not be able to pass through the pylorus. So there's an advantage in getting linear magnets, in that when you can have a very large anastomosis and still pass through the pylorus, the ileocecal valve, and getting expelled by defecation. Currently, we have from 32 millimeter to 80 millimeter magnets, depending on where you make the anastomosis, between the stomach, the colon, the biliary tree, the pancreas, the esophagus, etc. So for bariatric, on the small bowel, we have those three that we are currently focusing. And of course, they self-align correctly, and that is different than if you have 8 magnets with its polarity, where they can not necessarily get aligned, but misaligned, and you can have a misformation of an anastomosis. This is the breakdown between generation 1 and 2 of the magnets, because generation 2 has a biofragmentable flange, and we decided to do that because the all metal was keeping the healing tissue together and pinching it, and stayed too long at the anastomotic site. These are catheters holding the magnets for delivery by endoscopy. And you've got the laparoscopic positioner device. These are laparoscopic surfers. They have 5 force, because it's all dependent on the thickness of the small bowel, the resistance to the surfing, the tissue. You can have a normal tissue, muscular, non-muscular. For example, a thin colon is different than a very thick stomach, but it requires different force. It goes from 12 Newton to 26.6 Newton. We've got endoscopic retrieval device, and they're interesting for foreign body removal. So if you lost a magnet, or a magnet needs to be removed from the GI tract, we have these endoscopic magnets that you can use to retrieve these magnets. And as I said, there is non-magnetic instrument. This is an example of a liver retractor that is made of titanium entirely, as opposed to stainless steel. And laparoscopic instruments are being developed in other metal material. You have some bulldog clamp for clamping the jejunum if you want to deliver this to ligaments arthritis. So I've been working since 2007 on this concept, so it's an 18 years story. It's not a 5-year company story. And when I left Cornell, I teamed up with 2 engineers in 2007, and we came up with the concept of a duodenal-ileal anastomosis completely done by endoscopy. And this is one of the experiments that was published several years later. But in the endoscopy in the pigs, you can see a complete nice anastomosis, and compared to controls, the pigs that were growing versus the pigs who got duodenal-ileal anastomosis were not growing. And so we filed a patent in 2008 of this completely endoscopic duodenal-ileal anastomosis using magnets. So the patents are this old, and in 2008 we had the crash of the stock market, and we ran out of funding at that time. So we had to restart a second company to get those prototypes going and redo the animal experiments. So we came up with the 3 centimeter prototypes. This is one of the early prototypes that was not covered with titanium, but with a plastic material, and it was not aligning correctly when it was with the other catheter support. So we had to make very different prototypes to come up with this first 3 centimeter prototype. Just to tell you, the company was created in May 2020, and we did the first human in November 2021. So after 18 months of animals, we were ready to do human applications. This is on the looking back at the experiments. You can see the duodenum and ileum without very little scar tissue as compared to the enterotomy where it was closed with the sutures. And microscopically, it looked fantastic with good alignment of all the layers. Now, the basis of why a magnetic compression anastomosis is stronger than anything that we've seen before. How is this possible? Because you don't have any sutures or staples holding the tissue. Well, Michael Harrison at the University of California, San Francisco, used primates, enteroenterotomy anastomosis, and compared it with staples. And the burst pressure was more higher to rupture an anastomosis done with magnets compression than with staples. That was the first hint. He was unaware that the Russians had done similar studies in the rabbit and the intestinal anastomosis, magnet versus sutures. And for every day while they extracted the anastomosis, the burst pressure was higher all the time with magnets compared to sutures. So it's stronger than sutures and it's stronger than staples. And recently, the Chinese have redone these experiments for gastrojejunal anastomosis. Magnet versus control that was done with stapler. And you can see here faster time. There is a Nair score, which is the adhesions around the anastomosis. In magnetic, it's much less adhesions around the anastomosis. On top of that, they look at the granulation tissue under microscope, and the surface area of the granulation tissue was significantly less with magnetic than with control group. So they also look at TGF, beta-1, and other markers, and greatly improved anastomosis. So it's a better anastomosis, a stronger one, and I can assure you when you look at those in the intestine, the colon, and other tissue, you are amazed how perfect the anastomosis look like. Because there's no foreign body, there's no staples, there's no sutures, and it's your own healing capability of delivering collagen glue to this anastomosis. So we use the MAGD, the magnetic duodenal ileostomy, side to side as a marker, as an early study to look for the magnets and its application in the small bowel. The duodenal bipartition has some advantages because it stimulates, we think, the incretins. There's less absorption of calories and fat, and we have access to the duodenum for extraction of problems in the biliary tree, and it is fully reversible. With one stapler, you can disconnect and the patient goes back to where it was. There's no intestinal removal. And you can also increase the degree of malabsorption by stapling below the anastomosis on the duodenum and transforming a MAGD to a SADI. So this is post-sleeve gastrectomy. We started with this protocol, but then we also moved to type 2 diabetes without gastrectomy, just the magnetic anastomosis. Right now, there are 5 techniques to deliver the magnet. We started with a short colonoscope to deliver it to the trites. That's the lower magnet, and it's served to the ileum, and then another endoscopy to put the second magnet in the duodenum. Then we went in the second generation to swallow the first magnet and do the upper duodenoscopy. You can also do a direct ileal entry and either an upper duodenoscopy or upper swallowing. This avoids any endoscopy, and the double swallowing of the magnet at different times also avoids endoscopy. So there's an evolution in the choices. It remains a laparoscopic assisted procedure because you have to measure the intestine, and you can't do that with full endoscopy correctly. And if it's a delivery with the endoscope at the trites, we have to clamp the jejunum to avoid distension of the whole small bowel. So this is done with bulldogs clamps. This is the regular endoscope. There's no special endoscopes. And this is the delivery of the ligaments of trites, and then it is caught with our laparoscopic positioner device. The second endoscopy delivers the duodenum, the magnet in the duodenum, and you have a duodenal ileostomy performed this way with the bipartition. This is in November 2021, the first 5 cases were done in Tbilisi, Georgia. And this led to a publication on the first in human in obesity surgery. You can see the picture of the pair of magnets in the right upper quadrant in the first 5 patients. And we were successful in getting the anastomosis, and you can see here the excess weight loss reached 80% at 1 year, and we had a drop of hemoglobin A1C of 2 points. So this is a very anti-diabetic operation with the glucose dropping by 48 milligram per deciliter. In the second generation, as I explained, we made it so that it can be swallowed. Very thin, not as wide, and this is compared to the Allurion swallowing balloon. It's much smaller, thinner than a pill can. It's so easy to swallow that we are near 500 procedures, and I have yet to see a patient who has been unable to swallow a 4 centimeter, a 5 centimeter, or a 6 centimeter magnet. So this is amazing to me. This is how the patient comes in the morning of the surgery when they get to swallow. The swallowing is done with a sip of water, and in fact, many patients swallow the magnet without any water at all, as if it was a pill. This is a patient who comes for diabetes and is only going to get the magnetic procedure without any gastrectomy. So they come in the morning and they swallow the magnet, and 2 hours later we do an x-ray to confirm it's in the upper jejunum. Sometimes we have 3 or 4 patients come all in the morning and they swallow all the magnet at the same time. We take an x-ray and we say, this one's first, this one's second, this one's third, depending on where the magnet is, because they migrate at different speed. Once we have it in the jejunum, we bring the patient to the operating room. If you have a protocol with double swallowing, the second magnet is swallowed just before anesthesia, and you have your 2 magnets inside without any endoscopy. So here we have the titanium liver retractor, and we are splitting the greater omentum, and then this is to allow the ileum to go over the transverse colon, and we will measure the small bowel with an umbilical tape. I will just fast forward this, and at 250 centimeter, we will put metal clips to identify and radiologically identify the site of the anastomosis. We will then look for our magnet, and this is the surfer who has found the magnet in this patient at least a meter and a half down from the ligaments of Treitz after 2 hours after swallowing. And here we're still looking for in the jejunum as we're rotating this clockwise to orient ourselves, because you don't want to dock the magnets in a twisted position. If you have a twisted position and you've docked the 2 magnets, you can undock them, untwist, and redock. Would be different if you had done a stable anastomosis. and we will surf this jejunal position to the ileal clips, and it's a counter traction by this atraumatic bowel forceps. We sometimes have serosal tear, and they're coming from the forceps and not from the surfers. Now, while this is taking place, you may have not noticed, but the endoscopist has introduced the second magnet into the stomach and into the duodenum. And here we are docking the 2 magnets. It's more of a feeling than a visual aspect. And here you can see the endoscopic light. There's a catheter holding the duodenum magnet. This will be released. And after that, you can undock, redock, or position if you're not happy with the position of the magnet. We can micro-surf the magnets to a more distal position. The endoscopist is checking how far the magnet in the duodenum is from the pylorus. Here we will demonstrate a kind of a pushing away from the magnet from the pylorus, which brings the duodenal magnet and the ileal magnet together, moving distally. You can do the reverse. Sometimes we've docked them too distal and we're bringing them more proximal. We then have to close the mesenteric defect with non-absorbable suture, and this is an example, and then we're checking again that the biliopancreatic limb is not rotated. So this is a curve that has 112 patients post-sleeve gastrectomy with different sizes of magnets. The 3 centimeter, 4 centimeter, and 5 centimeter. The 5 centimeter is really a powerful magnet because it gives 80% excess weight loss at 6 months post-sleeve gastrectomy. It's a very, very powerful magnet. Most people start with a 4 centimeter because there's a low learning curve, and that one is around 36% of excess weight loss. We then did this experiment in type 2 diabetes with the swallowed magnet, as I demonstrated. This was 15 patients in Georgia, all diabetics. You can see here the body mass index was type 1 diabetes. The body mass index average was 33. We had 100% anastomosis, and the median expulsion time was 24 days. Three patients did not see it passed. This is the modest weight loss. We're not operating for weight, but mainly for type 2 diabetes, and we reached 44% excess weight loss. And this is the hemoglobin A1C curve of these patients and the drop of fasting blood glucose. Now, this is a 4 centimeter magnet. Now, we're repeating this with a 5 centimeter magnet, and we expect that the drop of hemoglobin A1C is going to be even more powerful in this instance. So we're following the patient, but more than half had lower than 6.5% so far. The magnetic gastroileostomy is, to me, this is going to be such a winner that you should pay notice, because the magnet between the stomach and the small bowel has not only bariatric application, but also has application for oncology in the partial or gastric outlet obstruction. But every hospital is going to be doing magnet between the stomach and the intestine for this reason. But it has a very strong application for obesity, and as here you can see the animal experiments at 6 days, the 6 weeks outlook of this anastomosis, and the 6 weeks inside of the stomach and small bowel anastomosis. It's such a pristine anastomosis that it is incredible. Every time I do this in the animals, in pigs, outside view, inside view. So after our animal experiments, we started in humans, and we used, we did not know the size of the anastomosis. So we used 60 millimeter, 70 millimeter, and 80 millimeter magnets. And they make anastomosis anywhere between 3 to 5 centimeter in diameter. So large enough that it never requires any dilatation stents or anything, because it's a large anastomosis. We had 2 choices in our anastomosis, but mostly we did gastroileal. And for long magnets, we had to do a gastroscopy under sedation to introduce the 70 millimeter. But the 60 millimeter is all swallowable, and the patients can swallow them without the need of a endoscopy. So for the long magnets, for large anastomosis, we deliver under sedation the magnet post-pyloric, and after 2 hours we confirm that the magnet has migrated from the duodenum to the jejunum. And then we introduce the second magnet by endoscopy, which is an easy endoscopy, because we just have to pop it into the stomach and then make a side-to-side anastomosis. The mesenteric defect is also closed, the Peterson's defect, because Peterson was described in a gastrojejunostomy, if you remember. And for weight loss, we tend to use a longer common channel of 300 centimeter, because we know that 80 to 90% of the flow goes through this anastomosis, as opposed to a duodenal ileostomy where the percentage is less. So this is what it looks like the day after in a human. And after passage of this magnet 3 weeks, 4 weeks later, you can see that it's gone. And some, believe it or not, some patients don't see them at 6 and 7 centimeter. So we published the first in human, and we are now at 41 patients. This is the first report at 20 patients. And not many patients were diabetic, unfortunately, but mostly for post-Lee gastrectomy, the average body mass index was 37. And we got some adverse event, but quite similar to the MACD experience. And the percentage of excess weight loss at 1 year was nearly 70% excess weight loss. So quite dramatic in terms of weight loss, more effective than the MACD at 4 centimeter. We still got an effect on hemoglobin A1C and mean glucose. 100% of patients were satisfied with this procedure and would recommend it to a friend or member of the family. So for the interest of time, I will finish with the last concept that we have for bariatric, which is the jejunal-ileal bipartition. This is Martin Fried, who has been doing this by laparoscopy with the stapler in Prague. And it is approved by the state for type 2 diabetes remission and surgery. And it's between the first 100 centimeter of trites and the last 150 centimeter of the ileocecal valve. It's a side-to-side anastomosis. There's no bowel resection, and the mesenteric defect is closed. So we decided to do this with magnets, with 5 centimeter magnets, and we went in Prague and did 10 patients with this. But we experimented with a double swallow technique. That is that the patient swallowed the first magnet. We have an X-ray confirming it's in the jejunum. They swallow the second one, and the two magnets join together in the abdomen and connect. So we then do laparoscopy. We disconnect them, surf them at the proper place, and reconnect them and close mesenteric defect with a suture. So entirely done without endoscopy. And it's amazing because Martin Fried said, well, maybe in the future we'll be able to swallow two magnets instead of pills every day, and maybe with external modifier of the magnetic field and get them at the right place, and the patients will be treated for type 2 diabetes. So that's becoming such a crazy thing, and the patients were monitoring their sugar. And the day that the anastomosis, the magnet passed, the sugar dropped before the magnets are out by defecation. And we were able to show that in several patients. This is the MRI demonstrating the open anastomosis. And he did also pill cam, and the pill cam took a picture of the anastomosis in the middle of the small bowel. So we have good anastomosis. An individual patient hemoglobin A1C, you can see the drop of each individual patient. So it is something in the works, and magnets are, I think, in the future a tool in your armamentarium, sutures, staplers, and magnets. And we're going to have more and more situations where magnets are preferable. They're being combined with robotics. We're going to have hopefully some presentation at ASMBS on robotic magnetic surgery, where entirely robotic with magnets, the anastomosis is done with the magnets. Thank you very much.
Sorry for the inconvenience. If the chairs can have the first row instead, you can sit on the first row. Oh, there? Okay. Okay. I think better. Do I need a mic with any of you? Do you need a mic? The cable supply is on the so tip for Sunday, when you get the robot, please don't use this cable.
So amazing, Michel. This is completely mind-blowing. So once the anastomosis forms, it acts like any other bypass would. So the results that we get are completely understandable.
Yes.
My two questions. Firstly, it's a compression necrosis going on between the two bowel walls. Have you been able to measure inflammatory markers like CRP or ProCal during the time this necrosis is going on, and does it have any adverse effect?
No, I have not
as compared to sutured anastomosis?
No, we've not done that. No, I cannot answer your question. We've not measured it. No.
And secondly, what is the ratio of the length of the anastomosis versus the length of the magnet?
Yes, the linear magnets makes half of a circle. So if you have a 5 centimeter magnet, the half circle is 5, so total circle is 10 divided by pi, 3, and you've got your diameter of the anastomosis. So a 5 centimeter magnet will make a 3.5 centimeter anastomosis, circular anastomosis. A 6 centimeter magnet will make a 12 divided by pi, a 4 centimeter anastomosis. So in the duodenum, we have smaller magnets of 4 centimeter, for example. So that's 8 divided by pi. It's more like a 2.5, 1 inch anastomosis.
Thank you.
Michel, just a quick question. Do you foresee a way of moving the magnets externally?
Yes. Yes. We know that in the pill cam, they're able to move it. So it's going to be a relationship. You will need a very strong magnetic field, but we have them in the MRI, for example, they're extremely strong. So we'll be able to move those magnets externally. It's going to be, so the problem becomes measurements of the intestine. You don't know where you are. Maybe with artificial intelligence, we'll be able to know where we are in the small bowel. And then there's still the mesenteric defect problem. How are we going to close this without surgery?
Interesting.
In terms of the gastrojejunal anastomosis and the preferential flow through that rather than through the duodenum, that presumably, or the question is it influenced by the size of the gastrojej? So can you calibrate, do you think, the effect of the operation? So you could put in very short magnets to get some kind of neurohumeral effect, but maybe not so much weight loss and much bigger white magnets, bigger anastomosis.
Yeah.
Do you think that happens, or?
I have a patient booked next month. The thing is, with the magnets, you can do as many anastomosis as you would like. You know, we think that patients can be treated with one anastomosis, but what about if you did a small magnet in the duodenum and the ileum, and then you've got another magnet with the intrum, and then you've got another one with the upper part of the stomach? You can end up with not only one hole, 2, 3, as much as necessary flow to get a response on this patient. So you can also enlarge the anastomosis. Once you have an anastomosis, you can put 2 magnets through the hole and enlarge it. If you have it too big, you can endoscopically go and close a little bit the anastomosis with endoscopic suturing. So everything is possible, and I just don't know the answer to your question because we're just starting to explore these different concepts.
Having get over your learning curve, the time the patient swallowed the first magnet to the time you actually finish the procedure, how long is the duration?
We have patients, you know, if your operating room starts at 8 o'clock, for example, we have the patient coming at 6 a.m. Or slightly before, and they swallow, there's a learning curve of how to manage this. If you want us to have a start time at 8 o'clock, then you can use the direct enterotomy technique, and that is very reliable. The patient is on the table. You can have opening of the ileum with 1 centimeter, put the magnet there, close this with 1 stitch, and have the endoscopy delivery and the 2 magnets, while the others that I have swallowed at 6 a.m., x-ray at 8 a.m., then you're going to find out if this patient is ready for, let's say, 9:30, 10 a.m. So the patient that has swallowed, if it's going down correctly and fast, after 3 hours of swallowing, the patient is in the operating room, and the procedure takes 30 minutes to 60 minutes. You know, the learning curve is short, 5 to 10 cases. And after 10 cases, you're down to 25, 30 minutes of a procedure. So it's 3.5 to 4 hours per cycle.
Thank you.
Okay.